On behalf of the coordinating team, I am extremely delighted to be here. We are all Indians and British, right? So we all have an affection towards cricket. So how awesome would it have been, if we had seen the debut matches when Ian Botham played, or Alistair Cook played, or Sachin Tendulkar played. So such is an awesome experience that we are going to see now, because most of the people who are going to speak now are debutants. They might turn out to be, rock stars of their field in the future. On that note, I'll just briefly describe how this will go on. So this is a flash talk. Each of the presenter is given 3 minutes. They start a brief introduction, which is their name and the institute from which they are affiliated to, and give their 3-minute talk, and no questions are asked. Then this goes on. There are some 14 speakers who are going to do this. A panel of judges have kindly agreed to evaluate their talks, as well as the posters, which are put both in this room as well as outside, as well as in this vestibule. So the judges will take all outside now. So the judges will, in their own time, evaluate the posters. We have given a scoring sheet, and the scores will be then computed, and tomorrow will be announced. And if anyone has got any questions on the posters, not necessarily the judges, the other audience, please reach out to one of the organizers who will set up a meeting with the person who has put up the poster. On that note, I'll first, can we have the slides up and ready? No questions. So I'll introduce the, I'll invite first candidate, Aniruddha.
Sorry. And their the visualization of the CNN using GradCam. So okay. So the problem statement. So why are we doing this? Why is this so important? So this is a very practical problem because high and low grade are the two different classes of urothelial cancer, which is cancer of the urinary bladder. And this directly correlates to the management decision. And this also affects the prognostication of the patient. And according to WHO, this is the single most criteria for which prognosis depends. Also, 90% of all cancers are urothelial in origin in urinary bladder, and it is on the rise because of smoking and other genetic factors also. So in this study, we use a real world data set, which I personally constructed out of the slides which I received in pathology department. And I used patch extraction to pre-process the data. I removed all the artifacts which were there and got a good data set on which to train the CNN. So what was the methodology? So this patch extraction was used. We can see on the left-hand side, these are the low-grade urothelial cancer at low and high power, and high-grade urothelial cancer in the middle at low and high power. And on the right side, we use a visualization technique, which is a saliency map showing the tumor hotspots. So here we can see the red areas are all tumor, and the blue areas and the green areas are showing stroma and blood vessels, which is not tumor. So in this study, we can say that the GradCam has correctly visualized many of the tumor hotspots. The results, So we got a very good accuracy of 90% in our test set. And this was about 60,000 patches of each class. So there were two classes, 60,000 of low grade and 60,000 of high grade. And we got about 90% accuracy. On the right hand side, we can see the graph. So the graph shows plateau after 25 epochs. So it shows that model saturates after 25 epochs, and it is able to correctly classify low grade and high grade in 90% of the cases. The 10% which inaccuracy which results is due to the heterogeneous nature of the tissue, which is unavoidable in all the urothelial cancer samples which we get in pathology. So we tried out many hyperparameters, but the best we got was 90% accuracy with this learning rate and batch size, which was 16, and batch size was 25, 32. Sorry. So conclusion, it was robust, and the model gave a good accuracy, and ultimately it can be used as a companion diagnostic test or as a screening tool before the pathologist makes a diagnosis. Thank you all.
May I request the next candidate?
A very good afternoon, all of you. Myself, Ankur Chaurasia, and I'm affiliated, I'm working as an assistant professor in Amity University, Noida. So our work is basically titling fuzzy logic based disease classification using similarity based approach with application to Alzheimer's. Now, the first question that wanders in my mind is why I have chosen this field. Because these days, we all are aware that how much uh, we are fighting with the neurological disorders. We have a lot of scope in working over the neurological disorders. The first thing. The second thing is that we these days our lifestyle, everything that is leading ourselves towards the neurological disorders. So over in this study we have targeted mainly the Alzheimer's disease. Further, we will move this study over the other neurological diseases such like Huntington and other diseases which are related with the neurological disorders. So in this study, we have simply taken the data set over which we applied multiple packages of R language just to identify the differentially expressed genes. Now, the human body is having several amount of genes, and we all know that the disease progression can be decided with the expression of genes. So in this study, we have simply targeted those we have simply targeted those differentially expressed genes which are causing the neurological disorders, right? So in this study, we have implemented some certain packages of R language, which were capable of giving us the differentially expressed genes which are causing the neurological disorders. Now, further, after the implementation of these packages, we have got our data normalized, and further, we have got the tabulated data where the data is segregated in various categories such as p-value and p-value, which are taking a vital role in which is playing a vital role in taking the decision towards the neurological disease, whether it's towards the disease progression or not. And after this identification, we implemented a fuzzy logic by using Mamdani model in just to make it a fuzzy logic based system to identify whether the disease progression can take place or not. So the future scope over this work is that we can target more neurological disorders where we can implement the similar algorithm and just to test the accuracy. In this, okay. In this, study, we have achieved 84% of accuracy, and we are still trying to tune up it up to a level of 90 or 90% or above. Thank you so much.
Thanks, Ankur. May I invite Nitya?
Good afternoon, everyone. I'm sorry this is not related to AI. So I am Vidya from Healthcare Technology Innovation Center, and I have a startup incubator there. And I'm presenting a device which is a point of care electrochemical immunosensor based serum placental growth factor measurement for preeclampsia screening at resource limited settings. So I did an 18-month fellowship, which was funded by BIRAC. It's called Social Immersion and Innovation Fellowship, where we underwent clinical immersion and rural immersion in different parts of the country. So one of the problem statements was that poor preeclampsia screening at low resource settings leads to preventable maternal mortality and morbidity. So widely accepted screening solution is the preeclampsia prediction model by the Fetal Medicine Foundation, which is a combination of maternal factors and ultrasound marker and the biochemical test. So what we thought is that the implementation of this in the low resource settings was very poor. That is what we observed. So so we tried to develop a solution, a point of care solution, which could replace the biochemical assay that can be done in point of care, which is usually done in a commercial lab. So that should be aligning with the WHO assured criteria of affordable, specific, sensitive, user-friendly, rapid and robust, equipment-free and deliverable. So this is more or less like a glucometer strip. So where there is a strip which is functionalized for PLGF detection in the clinical detection levels, and which is read using electrochemical measuring potentiostat, and which could be plugged into a computer or a phone. And that has a software that does the data analysis and display the quantification of PLGF. So we believe that this would improve the accessibility of biomarker-based preeclampsia screening to resource-limited settings. And also, we believe that this could bring up a technology roadmap for developing electrochemical sensors for similar applications. Thank you.
Next speaker is Naveen.
Good afternoon, everyone. My name is Naveen. I'm a PhD student at IISc. I'm working with Professor Fanny. So today I'll be presenting my work on the topic self-knowledge distillation for improving the generalizability of retinal disease diagnosis using OCT images. Next slide, please. Yeah. So OCT is a non-contact imaging modality that is typically used to diagnose retinal diseases by capturing the axial scans of the retinal layer. So if you look at a typical OCT setup is something like this. So we have some coherent source that emits light, and then this light is split into two parts via fiber coupler or beam splitter. Then we have a reference beam that actually captures the depth acquisition, and then we have a probe beam which actually captures the retinal tissue of our interest. Finally, once the echo comes back, due to the superimposition of the two signals which are coming from the reference beam and the tissue of our interest will be recorded by the signal processor. So if you look at, so if you just take the cross section of the fundus image, this is how a typical OCT scan looks like. So coming to the different kinds of abnormalities observed from OCT are like this. So we have choroidal neovascularization, which is CNV. Then we have something called diabetic macular edema, DME, and drusen. And finally, we have the normal retinal tissue. The main characteristics are there is subretinal fluid. There is a small cyst-like structure happening on the top of the retinal layer, and irregular retinal boundary corresponds to drusen. So during acquisition, as we have already seen that different characteristics form the kind of scan we are obtaining. Typically in the case of OCT, we have difference in SNR levels. So whatever AI models that are existing in literature till now, they do not generalize across the OCT scans with varying SNRs. One more problem we have seen is that the kind of deployability issue as OCT making stride towards point of care diagnosis have lightweight models which can be run in a resource constrained setting or of our interest. So we saw address this problem with a unified solution by proposing regularized lightweight models, wherein we propose to have a consistency from the prediction of the AI model by enforcing a divergence minimization criteria based on the KL divergence, where we enforce this constraint to restrict the predictions as in the form of a regularized form, so that irrespective of the SNR level, we have a similar prediction out of the OCT scan. So that way we have investigated our proposed method on 3 different benchmarking data sets at various noise levels. Interestingly, we have also observed that when we trained the AI model on one data set and when we tested it on the completely unseen data set, the performance of the proposed method was completely outperforming the existing techniques. So our method has been evaluated on 2 benchmarking architectures like ResNet 18 and MobileNet VT. Thank you.
Good afternoon, everyone. So I am Priyanka Narad. My topic is Deep Inception ResNet, a novel approach for personalized prediction of cumulative pregnancy outcomes in vitro fertilization treatment. So a bit of a rationale behind the work. Infertility treatment is an emotional and financial roller coaster. Repeated failure of implantation, that is defined as 3 or more failed in vitro fertilization cycles, where no clear cause can be identified, is a frequent heartbreaking endpoint where the emotional, physical, or financial burden of treatment becomes too high. Moreover, there can be complications associated with a live birth of a baby, such as ectopic pregnancy, miscarriage, etc. Artificial intelligence techniques have tremendous potential to help the field of infertility medicine. According to an article that was published in Indian Journal of Medical Research 2018, there exist several differences in the descriptors related to the Indian female population in comparison to their Western counterparts. For instance, the Indian women lose their ovarian reserve at a much earlier age, that is 46 plus minus 2, than Western females, that is 51 plus. And this results in lower success in implantation at a later age and a constant difference in ART outcomes. Also, there have been studies that have highlighted that AMH and AFC values are much lower in Indian women as compared to their Western counterparts. So we inferred that the existing models are not applicable to the Indian population since the values and range of the descriptors is different from the other parts of the world. So this was the total pipeline. We did the data acquisition across 3 years, 18, 19, and 20 from a reputed hospital in Delhi. The data preparation workflow included exploratory data analysis and data transformation through label encoding and one-hot encoding. We tried both without and with feature selection algorithms with train and test split of 60-40, 70-30, and 80-20, and applied all the state-of-art algorithms along with deep inception residual network, which gave us the best accuracy. And this was what we implemented through this deployment of the work that we had done so far. So this was supposed to be a video, but it's not working. So I'll just take you through. So for now, this is a work in progress, which is through a DBT funded project. The beta HCG was taken as the final endpoint, but we are working towards the live birth rate predictor. And this will give you a brief idea about how it will look like in the future. And that's all. Thank you.
Thank you. So next we have Chandra.
Good afternoon, everyone. I'm Chandrani from Institute of Mathematical Sciences, Chennai. So my topic for presentation is modeling a growing fetus and early warnings of abnormal growth. So first we try to model the fetal growth during the pregnancy period. So there are several standard growth models in literature. Intergrowth is one of them typically used, widely used. So they are basically based on regression fit and are complicated and unintuitive. So on my left hand side, these are the formulas that they use for the ultrasound measurement predictions. And we have proposed here the Gompertz growth formula, which is well established in the growth literature. And the formula is given by f of t equals to a to the e to the power exponential to the power minus c t minus t naught. Here t is the gestational age and f is the ultrasound biometry of our interest, for example, head circumference by perimeter diameter and so on. And A is the overall scale factor, T naught is the time offset, and C is the growth parameter. So there are several highlights from the modeling. So this Gompertz fits our in-house ultrasound data as well as better than the intergrowth formulas. And we can learn the parameter A for each fetus based on the ultrasound data and the maternal parameters like BMI of the mother and thyroid profile and anemic profile like that. And this enables us to predict the final dimension and birth weight with a good accuracy. And we can also predict abnormally developing fetus, which can have implications for gestational health. So here we have tried to compare our Gompertz growth formula with the intergrowth one. So from here you can clearly see that Gompertz are fitting well as compared to the intergrowth. On my left hand side, we have tried to see the good fit and bad fit patients. So good fit are basically if 3 or more measurements with the best fitting 90% are going, so that are good fit, and other last 10% are the worst fit complication, worst fit fetus. And in the good fit, we have less complications as compared to the bad fit, like SGA and LGA. You can see in the bad fit, we have larger percentage of fetus. Next, we have tried to predict the abnormal growth and birth weight from the early biometry and maternal data. So on my right-hand side, we have used the Gompertz formula for the fetal growth, and we have used machine learning lasso prediction method to predict the birth weight. And the red one shows that we have used the Gompertz formula plus intergrowth birth weight formula. And then last one, we have used both their birth weight formula and their growth model. And we can see that we, with our Gompertz and lasso, we are having highest correlation. And on my left-hand side, the figure ROC curve represents we are predicting the abnormal growing fetuses using the first 2 trimester data set.
So next, Naveen is going to share for us his Harihara and was able to join us.
Hi everyone, good afternoon once again. So I'm here to present the work on behalf of my colleague Mr. Hari, who couldn't attend this presentation. So his work was on the topic inference time adaptation of deep learning models, again for retinal disease diagnosis. So I'll just skip the intro part. So it is exactly the same one which I have discussed a few minutes back. Yes. So till now we have seen that, so a typical AI model has got 2 stages, right? So it has got training and testing. So once the model is trained, so the weights are freezed and you are allowed to only make inferences on the testing or the unseen data. But this test time adaptation is a new approach where people are trying to optimize the AI model after the process of training, especially to the data, that unseen data that is available out there. So the process involves optimizing the model parameters theta without having the annotation label of the unseen data during the test time. So for the same task, in this work, we have proposed some domain specific transformations using the acquisition characteristics of a typical OCT scan. So every OCT scan has got its own SNR, depending on the kind of acquisition and the machine and the expertise of the person who is capturing that particular scan. So what a typical clinician does there is that he tries to use some sort of denoising algorithms to have a clean scan and then make a prediction out of it. But what happens is that even you go for any denoising kind of algorithm, if you have an AI model trained on completely different SNR data, so even you try to denoise the scan and then try to infer it, the performance is very bad. So in order to maintain that, what we have proposed is to bring in some sort of consistency between the different domain specific transformations a clinician will look at. So here, the different domain transformations, what we have used are different denoisers. For example, in this case, we have used NLM, which is non-linear, non-local means filtering, the bilateral filtering, and the BM3, where we enforce the deep models parameters to give a consistent prediction, irrespective of the kind of denoising or the domain specific transformation that a clinician looks at. So interestingly, the proposed method outperforms the existing, the classical way techniques of having a robust retinal diagnosis. So the same is evident from different metrics that we have quantified in terms of F1 score and even in terms of accuracy as well. Our method is not only independent of the kind of domain transformation we are doing, but it is also consistent across different baseline models that we have chosen, where the proposed method outperforms the existing techniques in using the baseline models like ResNet 18, MobileNet V2, and ShuffleNet V2 as well. Thank you.
Our next speaker is
Hello everyone. I am Dr. Subhashish Sarkar. I am assistant professor and I am a general surgeon MBBS MS at a government medical college in Kolkata. And my title is that the smart prediction of IR-based detection of residual cancer. It is short. It is called a SPIDER. And I am the principal investigator in this project and also patented this device. And my other co-investigators are from Jadavpur University, Power Engineering Department, and Indian Statistical Institute with this image pattern recognition unit. And now we all know that the cancer, means the solid cancer, the best curative option is a surgery. There is no ifs and buts. If we can completely remove that thing, we have a very good prognosis. But if there is any kind of residual cancer, prognosis will be invariably post. So our main intention is to, during the real-time operation, if we have such a device which can say a surgeon that how much I have to resect or how much I have to preserve. If real-time visualization of the cancer tissue is available, then it will have a very good for the surgeons, because you know the CT scan, MRIs cannot be performed during the surgery operations. And our main intention is to achieve this R0 dissection margin, which is a microscopically negative dissection. And in this is the here we can see what is the margin R0 dissection and R1 or R2 dissection margins. And this is the schematic diagram of this instrument setup. And this is our this is a crude model which we are working now. And all these operations were done by me. First one is that image is, we can see a gallbladder operation done for a chronic cholecystitis or a laparoscopic cholecystectomy. We can see the pattern is homogeneous as it is a benign. Whereas the second case, it is a male breast cancer, and cancer has invaded the pectoralis major muscles, and we can see there is a clear cold spots showing there. The third one is these are lymph nodes, these metastatic lymph nodes from the axilla, and we can see that the demarcating cold spots are there. And fourth one is a case of a rectal cancer, which is done for this abdominal peritoneal resection. We can see a clearly visible this cold spot. This system comprises of one highly sensitive IR camera, infrared camera, two heating system of IR heating system, and one image processing unit. And this is the animal model. I mean, it's an animal model, the animal study which we are doing in this animal hospital. It is a malignant breast cancer of a dog, and here we can, when the flaps are raised, we can see there is a clear visible cold spot is there. Whereas when we have removed this cancer, then there is no cold spot. And this is the grayscale image. We are processing all those images in all the possibilities, and here we will applying this AI. But I am a surgeon, and I have I am a surgeon and I have no experience on this thing. So image processing people are doing this thing. Our main intention is to remove these artifacts. And as you know that the body surface is a little bit heterogeneous, and so remove all these things and incorporating all the details from the CT scan MRI, we are using this AI. Thank you, sir.
May invite Akansha to.
Good afternoon. Good afternoon, everyone. I am Akanksha Mishra, PhD student at IIT Goa. I am here to give a flash talk on deep learning and probabilistic approaches for cancer genomics. So this is a joint work with Dr. Flynn C. George from IIT Goa and Dr. Wei from Amazon. So we are using the popular cancer genomics dataset, the Cancer Genome Atlas TCG dataset, which consists of 33 different cancer types, and some cancer types have subtypes also. So we are mainly focusing on cancers related to breast, prostate, thyroid, kidney, and brain cancer. And for ease of discussion, I'll be talking about breast cancer. So in this data set, breast cancer have 20,000 genes with approximately 1,000 samples. So this is a case of high dimensional low sample size data. So we have pre-processed this high dimensional data set using some statistical technique, and using the reduced data set, we have plotted that graph. So in that graph, column represents the samples and row represents the genes, and the color from lighter shade to darker shade represents the low to high value of the genes. And at the top, you can see a bar which represents the different subtypes of the breast cancer. So from the literature, mainly this luminal A and luminal B dataset, luminal A and luminal B subtype is not easily separable. So you can see from the figure also, the gene values are almost similar for both the subtypes. So we have studied several probabilistic and deep learning based models, namely Lasso, extreme pseudo-sampler, learning to explain, and stochastic gates. So due to some or the other disadvantage of these methods, I will be focusing on stochastic gates. So this stochastic gates is a nonlinear feature selection based method which finds the subtype along with the set of genes that will be responsible for the cancer. So in this stochastic gate is based on the probabilistic relaxation of S0 norm, and this stochastic gate term comes from the Z variable, which is the continuous parameterization of Bernoulli variables. So more details about this model can be seen in the poster. Next, here are the results. So based on these models, I have applied these models on breast cancer, and with that we have obtained the highest accuracy using this STG model. And we have also applied this STG model on two datasets, synthetic dataset and one breast cancer dataset. So in the synthetic dataset, it identified the true features, and in the case of breast cancer dataset, it identified these set of genes. So out of that, BRCA2 is a tumor suppressor gene, which plays a significant role in hereditary breast cancer. Thank you.
Thanks, Akansha. I'll request Purushottam to give the next.
Hello all, this is great pleasure to be part of the event. I'm going to present So myself, I'm Purushottam, I'm founder of Deep Vital company. So I'm building a integrated the platform for mother and child healthcare. So I have graduated in a SPARSH program. This is basically for the mother and child health program. One of the clinical settings where I went, there is a clinical setting, one mother admitted for the labor, and immediately doctor, the primary doctor comes to the patient saying that we cannot assure the baby. Then finally we found that baby was aspirated for the meconium. And we identified the problem was there is a false positive rate of abnormal CTG patterns was very high. For knowing the reason was difficult for the differential diagnosis of problems like this, and increasing in cesarean sections as well. And mortality and morbidity cases are very high in the lower setting, which happen at 2 out of 10. Then we thought what we can do. Then we had a stakeholder discussion, and we found out that we can bring the new identified features which can identify those problems like meconium, which happens in low resuscitating. They can immediately refer the care where they can get the resuscitation very well. So that's why we're bringing the new device which can integrate with the light and then artificial intelligence and ECG which can able to detect the fetal heart races, so that we can early detection the what is the problem, so that we can refer the baby near to the clinical settings, and also exclusive for differential diagnosis. This is very important in the primary care sector because we wanted to refer the baby at the timely manner and timely clinical intervention, because we don't have much clinical people at the low risk. We wanted to refer them. And this is the expected outcome. Like we wanted to meet that unmet need which is happening, the differential diagnosis. And we are focusing only on the resource limited settings where the physicians are very less. And so we majorly we want to rule out the patients who are actually having the prone for getting complications. And as we are actually founder of the Deep Vital, I set my vision for challenging that. Like we are actually making the first India's digital twin model for the mother, so that we can identify the complication prior hand, so that it will give the early intervention for the mother, so that we'll get the better care. Thank you.
Thanks, Purushottam. Shafin is on stage.
Good afternoon. Myself, Shafin Sharaf. I'm PhD scholar from IIT Madras. My work is based on self-supervised deep learning framework for fetal heart imaging. And studies reveals that many newborns are symptomatic with congenital heart disease, and it is not identified or diagnosed early, which may lead to high mortality in the long term. And many researchers found that children with CHD are more likely to report worse health. And automatic analysis of fetal echocardiography screening images could aid in the identification of CHD. And this procedure is highly challenging since the fetal heart is indistinctly anatomically structural appearance due to is small with a relatively indistinct anatomical structural appearance, and also the presence of artifacts which also creates some complexity. Currently, fetal cardiac imaging is concentrated in the second semester for the early detection of anomalies. In India, Indian scenario is different compared to Western or developed countries, as many do not have access to anomaly. This may land at the delivery of place with fetal cardiac issues, and this jeopardizes the postnatal care of the baby. My objective is to develop an automatic diagnosis tool which could interpret the heart abnormalities during the routine echocardiography. And the tool can be applied in the clinical scenarios to support large volume centers, public health centers, and this reduces the workload of medical staff. Generally, sonographers use different views of fetal heart, namely four-chamber, LVOT, left ventricular outflow tract, RVOT, right ventricular outflow tract, and three vessel. Here I am showing the left ventricular outflow tract of the fetal heart. Using some convolutional neural network, we are classifying whether it is having some abnormalities. My expected outcome is once the tool is developed, it can be fetched with fax software, and this will detect anomalies which is missed during the second trimester. And the interpretation result will be conveyed to the primary unit through our security database. And if any abnormalities in the echo data, family counseling and further guidance will be given. And if there is any significant impact on optimal delivery and postnatal care of the baby, and the early detection is expected to improve the families and delivery units preparedness to handle the delivery and baby in the best possible way. Thank you.
Thanks, Shafin. Disha.
Hi everyone, I am Nisha, a PhD student from Jamia Millia Islamia University. I am presenting a research report on the study entitled as AI DOT, an artificial intelligence-based detection of oral cancer. Oral cancer affects 3 lakh people around the world every year, mainly in the countries like belonging to Southeast Asia continent. As the diagnosis of most of the cancer condition is based on histopathology images, for example, breast cancer, oral cancer is also one such condition. But every day pathologists face so many cases every day. There is a lot of burden on them for the performing diagnosis. In the meantime, this delays the treatment of the patient, and sometimes misdiagnosis also happens because of the overlapping features among the different oral disease conditions. These conditions are like oral submucous fibrosis, dysplasia, oral leukoplakia, which is a pre-malignant disease conditions arises. And when the overlapping features lies between them, pathologists find it difficult to provide the diagnosis in the less time. Hence, to overcome all these difficulties, machine learning tools can help if they are automated and also they are unbiased and faster. This is the design of the one such AI dog study, which can differentiate between the three different conditions like normal, oral submucous fibrosis, OSMF, and oral squamous cell carcinoma, OSCC. And once the oral cancer is diagnosed, the software can also provide the stage-specific diagnosis based on the histopathology images. So to begin with the study, we first collected the images from the mucosa, oral from the buccal mucosa region of the mouth. The tissue was collected, stained with H&E stain dye. For this, participating institute was six. The samples were collected from 6 different institutes. After collecting the tissue samples, slides were prepared and stained. Images were collected at 100x magnification, and these are graphs represents the number of images from each category. After collecting the images were allowed to be pre-processed, which includes stain normalization, random cropping, and flipping into 2 different directions, flipping and horizontal and vertical flip. After all these steps, the machine learning model was constructed. For this, the transfer learning approach was applied, and the 10 successfully pre-trained models were selected, out of which MobileNet V2 outperforms with an accuracy of 84.22. This model was then fine-tuned, and we were able to achieve an accuracy of 0.91 later. But this model still need to be validated on a new data set, on an unseen data set, so that we can understand about the adaptability of such machine learning models in the clinical practice. Thank you.
Thanks, Nisha. Next on stage is Swati.
Good afternoon, everyone. I'm Swati Padmanabhan. I'm working with Professor Jayaprakash as a PhD student from IISc Bangalore. So the work we are doing is development of polarization-based photoacoustic imaging system and appropriate mathematical models to enable the propagation of polarized light. So just a heads up, this work does not involve any deep learning. So I will start by introducing polarized light imaging. This technique has been existing, and it uses polarized light sources to study the structural and morphological changes in the tissue. So basically, we'll have an experimental setup in the conventional imaging system where a polarizing set of optics will be there, and then we'll have the sample, and again, the light outside is going to be detected by a series of optics. So we shall usually use some kind of transformation that is based on Stokes vector based on different polarized states. So photoacoustic tomography uses nanosecond pulsed laser, and when it is shown on a tissue, the absorbers absorb the light, and as a result of the thermal expansion, acoustic waves will be generated, which are detected using ultrasound, and then we reconstruct the image. So we are working on the part where if we modify the source to be a polarized source, what will be the corresponding acoustic change? So coming to major challenges, since PAT works basically on absorption, we have to figure out what is the analogous absorbed energy density as a result of polarization. The main challenges are what kind of intensities can be associated from polarized light, and it has main thing is the structural anisotropy of tissue, like it will have a lot of scatterers, layers, and different types of cells. So we figured out that so the techniques existing based on polarized light imaging use backscattered intensities. So we are figuring out whether to use degree of polarization and Stokes vector based intensity images and see whether we can recover information based on absorption and scattering, because polarized light images and the principle behind polarized light imaging is basically based on scattering. So the main methods that we'll be using is forward modeling using some Monte Carlo methods, which is a stochastic modeling method. And then we'll be extracting the absorbed energy density and then the time reversal acoustic reconstruction, which will give us the ultrasound output. And then using that, whether we can reconstruct a very good quantitative estimation of absorption and scattering using iterative reconstruction. So this is a work still under progress, and we have the results based on the Stokes intensities up till K-wave reconstruction. So we are yet to implement the iterative reconstruction part, and we focus on the experimental validation as well, so that we can understand the nuances of interfacing these two techniques to understand better. Thank you.
Thanks, Swati. I invite R. Mugaraj.
Good afternoon, everyone. Myself, R. Mugaraj, and from IIC Bangalore, and I'm working under the guidance of Dr. Jayaprakash sir. And now I'm going to share one of our work. So that title is deep planning methods hold promise for light fluence compensation in optoacoustic imaging. So optoacoustic imaging modality is a hybrid imaging modality, and it is currently evolving imaging modality in medical field, and it has the three process which is called optical process, photoacoustic effect, and acoustic process. And the main challenge in optoacoustic imaging is the fluence distribution is dependent on depth and wavelength. So that therefore then there will be a nonlinear distribution in the light fluence. So due to that, we cannot be able to recover the optical absorption coefficient very accurately. So the main challenge is we need to recover the optical absorption coefficient more accurately. Why? Because this is the main factor when we are doing the thermal therapy. So this is the workflow, how this is the actual MEA distribution or optical absorption distribution. So this optical absorption distribution we cannot be able to recover more accurately. Why? Because the nonlinearity nature in the optical fluence distribution. So in the third figure, we can be able to see clearly see we cannot be able to recover, or we cannot be able to visualize the deep vasculature or deep tissue in the reconstructed image. So that's why we need to recover more accurately by using deep planning method. And the conventional approach method is not suitable. Because we need to evaluate we need to estimate the accurate fluence distribution, and that is very difficult due to unknown of MEA distribution. So that is why we are going for the deep planning method. And for this method, we are using three different data sets, and the first one is vasculature data set. So basically, from the fundus image data set, we are extracting the vasculature nature, and then we are evaluating how the noise and wavelength is affecting the reconstructed image. And so this figure A is the reference image, and figure B is the reconstructed by the time reversal reconstruction method. And the remaining figures are remaining figures are from different deep learning texts, different deep learning neural network architectures. And from figure B, by comparison from figure A and B, we can be able to clearly see we cannot be able to visualize the deep vasculature due to nonlinear distribution of the fluence, as well as the more other factors also considering then which is known as. Okay. So here the SNR variation due to SNR, the deep vasculature is distorted more, and similarly when we are increasing the wavelength, the deep vasculature cannot be able to see as but if you increase the wavelength value more, then we can be able to clearly visualize the deep vasculature. And this is the 3D data set, breast data set. So here also by using different types of deep learning technique, we can be able to recover the recover the mu distribution, and from the line plot we can be able to visualize that one. And that one is in vivo data set. We analyzed with in vivo data set also, so it can be able to improve the contrast of the image. That's it. Thank you.
Thanks, Raj. Next, final moderator is Isha.
Good afternoon, everyone. I am Isha, and I'll be presenting the work titled as Deep Learning Based Method for Reducing the Transducer Effects in Photoacoustic Tomography. So as like in the previous presentation, they have already explained about the photoacoustic tomography, so I'm not going into that definition. But in this photoacoustic tomography, there are some challenges are associated, like how we are illuminating our sample and what kind of light source we are using there. And also on the detector side, what kind of detector we are using, like what is the bandwidth of the transducer, or what is the response or the geometry of that transducer, and along with that, what is the coupling method we are using, or the reconstruction algorithm after acquiring the data. On the reconstruction algorithm, it is the image quality depends. So in this, I'll only talk about the impulse response of the transducer. So as you can see, there one equation is written. So that is whatever signal is getting detected by the transducer, so that is affected by the impulse response of the transducer. So that is also there is spatial and electrical impulse response of the transducer. So in this work, I have only focused on the spatial impulse response part. So in the below figure, you have seen if the actual signal is look like a bipolar signal. So depending on the SIR of a particular location for that transducer, the signal that is getting recorded by the transducer will look something somewhat different compared to the actual signal there. So to remove this SIR spatial impulse response effect, I have used this FD unit architecture there. After reconstructing the image, so this is the FD unit architecture that I have used. So this is the pipeline that have been used for this project. So these are the results. So in this, I have worked on two different transducer configurations. First is this linear array configuration, where 8 transducers are kept in an octagon fashion, and other is the concave array transducer. So as you can see in this linear array, so next to this is the sensitivity field of this orange colored region. So since these linear array transducers are not the focused one, so the sensitivity field is more there. But on the other side, that concave array is the focused one, so only the focused region is having the higher sensitivity. So the same thing we can see in this in the results also. If this is the actual, like in the first image, if this is the actual vasculature that is presented there, then after acquiring the signal and reconstructing the image, that will get affected based on this sensitivity field of that transducer configuration there. So there also that vasculature is somewhat getting lost. Like the outer region is looks like black there, so we are not able to see the vasculature completely there. So for that, we have used this BPD salsa algorithm, which is the conventional algorithm, and next is the FD unit architecture, and compared the result for both cases. So the thing is, in the FD unit architecture, it's recovering the complete image, but for this conventional algorithm, still on the corners, the contrast is not so good.
Thanks, Isha. This concludes all the flash talks. I'm very thankful for all the young investigators who were very enthusiastic in coming forward and sharing their work. I'm sure by the time they go back, they will have good feedbacks from the experts who are here. I would also like to thank Doctors Aris, Manindra, Jain, Ashok, and Mouli for evaluating this posters and this talk, and the rest of the organizing team for putting together in a synchronized fashion.
Thank you, everyone. Thanks for all the speakers. It's very heartening to see people from different backgrounds working in this interdisciplinary field, including people from medicine, engineering. It's very nice to see. And I hope, as Ram said, you'll get a nice feedback and get to meet good people and get an advice on your careers as well in our last session today. So, and I would like to thank Dr. Ram, Dr. Mouli, and Dr. Alice for wonderfully conducting this session and coordinating it.